Welcome to the deep dive. Today, we're really digging into a condition that many people know of, but maybe don't fully grasp: Parkinson's disease, PD.
Right. And when we talk about PD, what we mean is it's a progressive neurodegenerative disorder.
Hmm.
The core problem is the gradual loss, the dying off of dopamine-producing neurons.
Dopamine, okay. And these are in a specific brain area.
Yes, deep inside the brain, in a place called the substantia nigra. These cells are crucial.
And this isn't rare, is it? The numbers are quite staggering.
No, not at all. It's actually the second most common neurodegenerative condition out there. Only Alzheimer's affects more people. We're talking nearly 1 million Americans and around 10 million globally.
So, a huge impact. Our goal today, our mission for this deep dive, is really to get past just the surface level understanding.
Exactly. We want to navigate the complexities, focus on maybe some of the early signs people miss, the non-motor stuff, not just the tremor everyone thinks of, and look at how treatment is evolving.
Because it's not one size fits all, right? The sources really stress that.
Absolutely critical point. Symptoms develop slowly,
Right.
and how fast it progresses, what symptoms someone gets, it varies hugely. That diversity is, well, it's fundamental to understanding PD.
Okay, let's start with that core science then. Dopamine deficiency. You said these neurons die off in the substantia nigra. How does that actually affect movement?
So think of dopamine as the key chemical messenger for smooth, coordinated movement. It sends signals along a specific route, then a gross-trail pathway, almost like a communication line.
Mm-hmm.
That line connects the substantia nigra, the factory, to another area, the corpus striatum, which executes the movement commands. When those dopamine cells die off,
The signal gets weaker or lost.
precisely, the
Yeah.
communication breaks down, movement becomes slow, difficult, less automatic.
And the really shocking thing the sources point out is that you don't even see symptoms until a huge percentage of these cells are already gone.
Yeah, it's quite sobering. Typically 60 to 80%, sometimes even more, of those dopamine cells are lost before the classic motor symptoms become obvious.
60 to 80%. That implies the disease process started long before diagnosis.
Years before, maybe a decade, maybe longer. So when we start treatment, we're already playing catch up on damage that's been happening silently.
Wow. Okay. What about who gets it? Are there clear risk factors?
Well, the single biggest risk factor is just getting older. Most people are diagnosed in their 60s.
And there's a gender difference?
Yes. Men are about 1.5 times more likely to develop PD than women. The reasons for that aren't fully clear, but the pattern holds.
What about genetics? Does it run in families?
Sometimes, but it's less common than you might think. Genetics are linked to maybe 10–15% of cases. For most people, the cause is, frankly, unknown.
Unknown.
Yeah, the leading theory is it's probably a mix. Some underlying genetic susceptibility combined with environmental factors. Exposure to certain pesticides, maybe industrial chemicals, head injuries. It's complex and still being researched heavily.
Okay, so when someone does start showing symptoms and they see a doctor, what are the sort of classic motor signs they're looking for, the cardinal features?
Right, there are 4 main ones, though you don't necessarily need all 4 for a diagnosis. First and most recognized is the tremor.
The shaking.
Yes, a rhythmic shaking. Often starts in just one limb, like a hand or a foot, sometimes the jaw. And it's typically a resting tremor.
Meaning it's worse when you're not doing anything.
Exactly. It's most obvious when the hand is resting in the lap, for example. Often described as pill rolling, like rolling a small pill between the thumb and forefinger. It tends to decrease or disappear during purposeful movement or sleep.
Okay, what's next?
Second is bradykinesia. That's the medical term for slowness of movement.
Slowness. That sounds like it would affect everything.
It really does. Simple tasks become incredibly difficult and time-consuming, getting out of a chair, buttoning a shirt, cutting food. It also leads to less spontaneous movement, like fewer facial expression.
The masked face look?
That's part of it, yes. A reduction in those automatic movements. Third is rigidity.
Stiffness.
Yeah, muscle stiffness. The muscles feel constantly tense, kind of tight or achy. A doctor might feel it when moving a patient's limb, like a cogwheel sensation.
And the fourth?
Postural instability. This usually comes a bit later in the disease, but it's about problems with balance and posture. People might start to stoop or hunch over. This unfortunately increases the risk of falls.
And you mentioned earlier this often starts on one side.
Yes, that asymmetry is a very common pattern. Symptoms typically begin on one side of the body, say the right arm trembles. And even as the disease progresses to affect both sides, it usually remains worse on the side where it started.
Okay, that covers the sort of classic motor picture. But the sources really emphasize these earlier, non-motor signs, things that can show up years before the tremor or the slowness.
This is so crucial and often overlooked. We have to stress, like the sources do, having just one of these doesn't mean you have PD. But if you notice more than one, it's definitely something to discuss with your doctor.
And many of these are, well, they seem unrelated to movement at first glance.
Right. Many involve the autonomic nervous system, the body's automatic functions.
Yeah.
It really shows PD isn't just about movement. It's a wider neurological issue.
So what's a big one?
One of the most significant and surprising to many is loss of smell, hyposmia.
Really? Losing your sense of smell?
Yes, it's incredibly common. Almost everyone with PD experiences some change in their sense of smell,
Yeah.
and roughly a third lose it completely, sometimes years before motor symptoms appear.
Can they smell anything or specific things?
The sources mention specific scents people often have trouble with, like bananas, dill pickles, licorice. And it's not just about enjoying food. Think about safety.
Not smelling smoke or a gas leak.
Exactly. It's a real concern.
Yeah.
So working smoke detectors become even more vital.
Wow. Okay, what else falls into these early warnings?
Sleep problems are another major category, particularly something called REM sleep behavior disorder, or RBD.
REM sleep, that's the dreaming stage, right?
Correct. And normally during REM sleep, your muscles are temporarily paralyzed. It's called atonia, stops you from acting out your dreams. In RBD, that paralysis fails. So people literally act out their dreams. They might shout, thrash around, punch, kick, even fall out of bed.
That sounds quite dramatic and potentially dangerous for them or a bed partner.
It can be, yes.
Ah.
And it's a very strong predictor, often appearing years, even decades, before other PD symptoms. It suggests the disease process is affecting the brainstem early on.
Are there other sleep issues?
Yes. Excessive daytime sleepiness is common too, not just feeling tired, but sudden, irresistible urges to sleep attacks that can happen during activities, even while eating, working, or concerningly driving.
Okay, loss of smell, sleep problems. What about changes you might notice physically, but not necessarily in movement itself?
Good question. Constipation's a big one, and perhaps one of the earliest non-motor signs.
Constipation, how is that related?
It affects about 3 out of 4 people with PD. The disease damages the autonomic nerves that control the gut, slowing down bowel motility. It can precede the motor symptoms by many years, sometimes even 20 years.
20 years. That's incredible.
It really highlights how long the underlying process can be going on. Another subtle change is in handwriting. It can become very small and cramped. That's called micrographia.
Letters getting smaller and bunched together.
Exactly. And changes in the voice, too. It might become very soft or low, almost monotone. People might find others are asking them to speak up or seem like they're losing their hearing.
And posture. You mentioned postural instability later, but are there early signs?
Yes. Family or friends might notice someone starting to stoop or hunch over more than usual. It's a gradual change in posture.
And the masked face you mentioned earlier.
Right, facial masking. It's not that the person feels serious or angry, but the loss of those small, automatic facial movements, blinking, small smiles, can make their expressions seem flat or unhappy.
Okay. One more from the sources. Dizziness.
Yes, dizziness or fainting, especially when standing up. This is usually due to orthostatic hypotension.
Meaning blood pressure drops when you stand.
Correct. The autonomic system, again, failing to properly regulate blood pressure when changing position. So you stand up, blood pressure plummets, and you feel faint or dizzy.
So taken together, these non-motor signs paint a much broader picture of PD than just movement issues.
Absolutely. And that brings us to treatment, because managing these non-motor symptoms, or NMS, is just as important, sometimes more important for quality of life, than managing the motor ones. It busts the myth that PD is only a motor condition.
Right. For some people, these NMS are actually more disabling. So how do you tackle something like, say, the constipation?
You start with the basics. More water, definitely more fiber things like bran, lentils, prunes are good. Gentle, moderate exercise helps stimulate the bowels too.
And if that's not enough?
Then you might move to over-the-counter options like bulking agents, Metamucil for example, or stool softeners. Laxatives are usually a later resort.
What about drooling? That sounds like an uncomfortable symptom. Affects about half of people.
Yes, around half. And the key thing to understand, the sources say, is that it's usually not because the person is making more saliva. It's because they're swallowing less often due to the bradykinesia affecting those automatic mouth movements.
Ah, okay. So what helps?
Simple things first. Chewing sugar-free gum or sucking on hard candy can prompt more frequent swallowing. If it's more severe, doctors might prescribe atropine drops under the tongue, or even botulinum toxin Botox injections into the salivary glands to reduce saliva production.
Okay. And the dizziness, the orthostatic hypotension.
Management there is often about behavioral changes. Avoid standing up too quickly. Elevate the head of the bed slightly when sleeping. Maybe slightly increase salt intake, under medical advice, of course. Compression stockings can help too.
Are there medications for severe cases?
Yes, if lifestyle changes aren't enough, drugs like domperidone, fludrocortisone, or midodrine can be used to help stabilize blood pressure.
Let's circle back to sleep and mood. You mentioned RBD, acting out dreams. How's that treated?
If it's mild, sometimes no specific treatment is needed beyond making the sleep environment safe, maybe bed rails or padding on the floor next to the bed.
Safety first.
Definitely. For more problematic RBD, the main treatments are melatonin, often starting at 3 milligrams before bed, or a low dose of clonazepam.
And general insomnia, difficulty sleeping.
Good sleep hygiene is paramount. Regular sleep schedule, limit time in bed to maybe 8 hours, use the bed only for sleep and sex, avoid screens before bed, all the usual advice. But it's important to recognize insomnia and PD can also be due to the brain changes themselves.
What about mood? Depression, anxiety, these can be early signs too, right?
Yes, they can predate motor symptoms, and they're often a direct result of the neurochemical changes in the brain, not just a reaction to the diagnosis. Management is multifaceted. Social connection is vital. Regular exercise helps mood significantly, and therapy, like cognitive behavioral therapy, CBT, can be very effective.
And medications.
Absolutely. Antitussins are often needed. The sources mention nortriptyline and citalopram as examples that are commonly used and effective in people with PD.
Okay, shifting towards later stages, cognitive issues can arise.
Yes, cognitive impairment or even dementia can develop, usually later in the disease course. Symptoms often involve trouble with attention, planning, multitasking, decision-making, what we call executive functions, and just slower thinking.
Is there treatment for that?
Medications called cholinesterase inhibitors, like rivastigmine or donepezil, which are also used in Alzheimer's, can offer some benefit for cognitive symptoms in PD.
What about psychological issues, like hallucinations?
Hallucinations occur in about a third of people with PD, usually after many years. They're almost always visual.
Seeing things that aren't there.
Yes. Often they start as illusions or misinterpretations, then maybe seeing spots, flashes of light, insects, or sometimes fully formed figures, like small people or animals. It's usually not frightening initially, but can become so.
How is that managed? It sounds challenging.
It is. The first step is often to review the person's PD medications, as some can contribute to hallucinations. Sometimes reducing the dose, especially of dopamine agonists or amantadine, can help. If needed, certain atypical antipsychotics like quetiapine or clozapine might be used cautiously.
You mentioned dopamine agonists. That brings us to another really difficult issue, impulse control disorders, or ICDs.
Yes, this is a really critical side effect to be aware of, particularly with a class of drugs called dopamine agonists. Common ones are pramipexole and ropinirole.
What kind of impulse problems are we talking about?
It can manifest in several ways: compulsive gambling, hypersexuality, binge eating, compulsive shopping or spending, really excessive out-of-character behaviors.
Why do these specific drugs cause that?
Because they directly stimulate dopamine receptors, including those involved in the brain's reward pathways. In some individuals, maybe 1 in 8 on these drugs, according to sources, this leads to an overstimulation, driving these compulsive behaviors.
That sounds devastating. You have a drug-helping movement, but potentially ruining someone's life in other ways.
It's a terrible dilemma. The primary treatment is usually to reduce the dose of the dopamine agonist, or switch to a different class of medication if possible. Awareness and open communication between the patient, family, and doctor are vital here.
This really underscores the complexity. Since there's no cure yet, treatment is all about managing symptoms to maintain function, right?
Exactly. The goal is functional independence for as long as possible.
Yeah.
And the strategy often involves careful timing and balancing act with medications.
Like you said, maybe delaying levodopa, even though it's the most effective.
Right. Because while levodopa is still the gold standard for symptom control, long-term use, especially at higher doses, is linked to developing motor fluctuations, periods where the medication works on time and periods where it wears off, and also those involuntary movements, the dyskinesias.
So doctors might start with alternatives like those dopamine agonists, despite the ICD risk, or other meds.
It's a conversation. Dopamine agonists do improve symptoms, and there was some research investigating if they might even be neuroprotective, though that's debated. But yeah, the known risks of daytime sleepiness and ICDs are significant drawbacks.
What are the other main medication options then?
There are MAO-B inhibitors, like rasagiline or selegiline. They offer mild symptomatic relief and might help delay the need for levodopa,
Okay.
and there's amantadine. It can improve function, well, sometimes quite significantly, but maybe only in a smaller subset, like 20% or less. It has its own side effects to watch for, like hallucinations, confusion, or swelling in the legs, edema.
All right, let's tackle another myth the sources highlight. Deep brain stimulation. DBS. People think it's experimental.
Definitely not experimental.
Right.
That's myth 6 busted. DBS has been a standard FDA-approved treatment for well over 2 decades now.
So how does it work? It's surgery, right?
Yes, it's brain surgery. Electrodes are implanted into specific target areas in the brain. Common targets are the subthalamic nucleus, STN, or the globus pallidus interna, GPI. These electrodes are connected by wires under the skin to a neurostimulator, like a pacemaker, usually placed in the chest.
And the stimulator sends electrical pulses.
Exactly. It sends electrical impulses to those brain targets to modulate the abnormal brain activity that causes the motor symptoms.
And it's effective.
Highly effective for the cardinal motor symptoms, tremor, rigidity, bradykinesia. It's also very good at reducing the dyskinesias caused by levodopa.
Who's a good candidate?
Generally, it's recommended for people who've had PD for at least 4 years, are still responding well to levodopa, but are experiencing significant motor fluctuations or troublesome dyskinesias that aren't adequately controlled by medication adjustments.
But it's not a cure, right? It doesn't stop the disease.
Crucially, no. DBS is purely a symptomatic treatment. It helps manage the motor symptoms incredibly well for many people, but it doesn't slow or stop the underlying progression of Parkinson's disease itself.
Okay. That leads us to another myth. Myth 4, the idea that apart from medication or surgery, there's nothing else you can do.
That is absolutely false and a really harmful misconception. Lifestyle, particularly exercise, is hugely important.
How important?
Critically important. Exercise provides clear symptomatic benefits, improves gait, balance, flexibility, mood. And there's growing evidence it might even be neuroprotective, potentially slowing the disease process itself, though more research is needed there.
What kind of exercise?
The recommendation is usually 150 minutes of moderate to vigorous intensity exercise per week, and ideally incorporating 4 types. Aerobic activity like brisk walking, cycling, swimming, strength training, balance, agility, and multitasking exercises, think yoga, tai chi, dance, even non-contact boxing, and regular stretching for flexibility.
And the sources had a key safety tip about timing.
Yes, very important. Try to exercise during on periods when your medication is working well and movement is easiest and safest. Reduces the risk of falls or injury.
So medication, possibly DBS, and definitely exercise. Anything else on the horizon? Let's bust myth 7, that research isn't progressing.
Oh, research is incredibly active. There's a huge focus now on finding neuroprotective strategies, treatments that could actually slow or stop the loss of those dopamine neurons, trying to fix the factory before it fails completely.
What kind of approaches are being looked at?
Several angles. Things like trying to boost the function of mitochondria, the energy producers in cells, using supplements like creatine or coenzyme Q10, looking at anti-inflammatory drugs, exploring whether existing drugs for other conditions like certain calcium channel blockers used for blood pressure might have a protective effect, even investigating things like uric acid levels.
So lots of avenues being explored.
Definitely. The field is moving, although finding that truly disease-modifying therapy remains the biggest challenge.
So wrapping this up, the big picture is that Parkinson's is incredibly varied. It demands a really personalized approach to care.
Absolutely. It's not just the tremor. It's this whole constellation of motor and non-motor symptoms. The loss of smell, the constipation, the sleep issues, anxiety, cognitive changes that often need just as much, if not more, attention.
Which means you need a team, right? Not just one doctor.
Ideally, yes. A neurologist, preferably a movement disorder specialist, working alongside physical therapists, occupational therapists, speech therapists, mental health professionals. A multidisciplinary team approach gives the best outcomes.
And a quick word for care partners. It's a journey for them, too.
Immensely so. The sources emphasize flexibility in planning, because the disease can be unpredictable. Open communication is key. And crucially, care partners need to prioritize their own well-being and seek support. You can't pour from an empty cup.
Absolutely. So for our final thought, You've mentioned several times how these non-motor symptoms, like loss of smell or RBD, can show up years, even a decade or more, before the motor symptoms that currently define PD diagnosis.
Yes, that latency period is really striking.
So the provocative question is, if the underlying physical degeneration starts so early, and the first signs are often non-motor, what does that mean for the future? Could we, or should we, start diagnosing PD based purely on these non-motor signs?
That's the edge of current thinking. If the key to truly slowing the disease lies in intervening much, much earlier, maybe before significant motor symptoms even appear, well, then our whole definition of early diagnosis might need to shift.
We might need to redefine Parkinson's almost, focusing first on these autonomic or sensory changes, rather than seeing it primarily as a movement disorder.
It's a potential paradigm shift.
Mm-hmm.
Focusing on that very early premotor phase could completely change how we research, diagnose, and ultimately treat Parkinson's in the coming years. Something to definitely keep an eye on.